My pleasure this morning to introduce live real people that are going to talk about a variety of things. And having said that they're live, I'm now going to introduce a video. So this is not live, but this is Sarah Havord. And Sarah is the VTE prevention lead from Oxford. And she's going to talk about the emotions experienced by cancer patients with a venous thromboembolism. So over to Sarah. Technical, here we go.
Now, my interest for joining the service was down to the fact that I saw many surgical patients developing blood clots during admission and after they were discharged from hospital, and I just simply wanted to find out more. It's great to have the opportunity today to present to you my work, which I undertook last year at Oxford Brookes University, where I successfully achieved my master's in nursing. Now, I decided to do my dissertation on a topic that would focus on an unanswered question. I chose what emotions are experienced in cancer patients with a venous thromboembolism, VTE. Now, a quasi-systematic review was applied as a design for this literature review, which has several steps with the aim of answering a research question in an ethical and rigorous way, helping to uncover missing knowledge on a specific topic and justifying the research question given the time and resource limitations available. A quasi-systematic review helps to provide high-quality evidence supported by evidence-based practice, completed in a systematic way involving 5 steps, which are asking the research question, acquiring the evidence, appraising the evidence, analysing the data, and then lastly, discussing what has been found and what is left to find out. I used the PEO tool in order to help me develop my research question. At the start of this piece of work, it was really important for me to acknowledge my interest in VTE and cancer, which has been influenced by my role. I frequently see cancer patients diagnosed with a blood clot, they're treated and then discharged from our service. But then I'm often left wondering, how is this affecting them emotionally and how best can we support them? Not only have they just been told they have a life-threatening cancer, but now a life-threatening condition, the VTE, to contend with also. This was also of particular interest to the All-Party Parliamentary Thrombosis Group back in 2016, and they identified that there is a need to recognise the emotions experienced by cancer patients and how best to manage this due to not being currently addressed, and it's still not addressed today. Therefore, identifying the emotions experienced by cancer patients with a VTE could help improve understanding and awareness amongst healthcare professionals and those affected. Therefore, the emotions such as the thoughts, the feelings, the perceptions of cancer patients with a VTE was critically analysed for a comprehensive quasi-systematic review of the relevant research available. So to provide you with some background, cancer-associated thrombosis, CAT, is a leading cause of death in patients with malignancy, and 50% of patients with cancer will have a VTE event within 3 months of their cancer diagnosis. The psychological impact of cancer alone impacts significantly on patients' quality of life, and 45% of cancer patients report that physical challenges are much easier to cope with than the emotional effects of cancer. The psychological effects of VTE alone have also been well recognised, such as the quality of life being much lower in those who have had a VTE event compared to the general population. It's also been found that having a VTE event is a life-changing, traumatic event, with the uncertainty and fear of the recurrence, as well as feeling let down by healthcare professionals. However, the emotions and feelings experienced by cancer patients living with a VTE are not recognised. Therefore, the aim of the study was to evaluate the combined emotional impact of cancer and VTE. So 4 databases were used that I felt were relevant towards my research question to find the relevant literature available. I used the British Nursing Index, Inaul, PubMed, and the PsycInfo. I then applied an inclusion and exclusion criteria, and search terms were created in order to search the databases systematically. The Prisma diagram shows each step taken, ending with 6 papers relevant towards answering my research question. Now you can see that the numbers at the beginning were very large, and I managed to narrow that down to 6. The 6 articles were then reviewed, evaluated, and critiqued using the Joanna Briggs Institute Critical Appraisal tool to help understand how authors had made their decisions and conclude if they are trustworthy or not. These were the 6 included studies within my research. Reflective thematic analysis, guided by Clark and Braun, was then applied to analyse and report patterns of meaning to address the research question in a manageable way, to identify and developing connections between the included studies, guiding data synthesis. This involves 6 stages. Step 1, become familiar with your data. 2, generate initial codes. 3, search for the themes. 4, review the themes. 5, define them themes. And 6, report them findings. The results. So 2 main categories were discovered from participants' reports, and developing from those were themes that affected the participants' experiences. In the first category, the initial reaction to VTE was influenced by the threat to life and lack of knowledge theme. And in the second category, coping with VTE was influenced by setback and the acceptance of treatment theme. So I'm now going to go through each of the themes individually. So the findings suggested that cancer patients with a VTE event expressed a threat to life due to the shock and the symptoms associated with the lack of information provided by healthcare professionals. 7 participants from 5 studies described the initial VTE event as a shock, even if they had a previous VTE event. This led to the theme threat to life being developed. The terms used to express the emotions and to describe this threat to life were shock, surprise, dangerous, and playing with your life. One participant said, "It's a shock at first," and another stated, "I almost died because I didn't know I had a PE, and that frightened me." The threat was caused by VTE symptoms from multiple papers. 9 participants found that symptoms of VTE to be distressing and used statements such as gasping for air, more trouble with my chest than my colorectal cancer, a sudden onset of not being able to breathe, and questioned if I'm going to die. 2 participants were shocked due to not recognising the symptoms of a VTE, with statements such as, "During my cancer treatments, I was never told that there was a risk of getting a blood clot. I didn't know about it. I was pretty shaken up." Another said, "I have never heard of a VTE, so that was why I was so shocked." Lack of knowledge theme. Now, little prior knowledge of the association between cancer and the risk of VTE, along with the symptoms that accompany, was identified amongst participants and healthcare professionals. This highlighted the importance of healthcare professionals providing this information along with support once diagnosed with VTE in several of the studies. 5 participants reported not being told or aware of the increased risk of symptoms of CAT, with actually long-haul flights being voiced by 3 participants as being the biggest risk factor for VTE. Participants mistaking their VTE with other conditions were identified in several studies. One participant stated, "I felt I was having a heart attack. That stress made the symptoms worse." Many participants concluded it was a heart attack first rather than a PE event. 2 participants thought it was their other conditions worsening, with one stating that their symptoms were a result of their asthma, and the other thought it was their chemotherapy treatment causing the changes in their breathing and not the VTE event itself. A delay in healthcare professionals diagnosing the VT event was acknowledged in 2 studies, with participants experiencing a delay in a VT diagnosis. One participant said, "They said it was probably pleurisy, gave me antibiotics, it was a pain I'd never had before." In one study, a participant had symptoms of a DVT, which was dismissed by healthcare professionals, and sadly it later developed into a PE event. A lack of support when being diagnosed with VTE was reported in 2 studies, with 3 participants feeling rushed with limited explanation. One stated, "The doctors don't say to you, if you don't feel better, come back in a couple of days. They just give you a prescription, if you've got to have one, and then through the door. I've got nobody to turn to." The third theme, setback. In several studies, a setback was identified in CAT patients, as not only had they just been diagnosed with cancer, they now had another condition, the VT event, to deal with, and the consequences that come with the VT event. Having another health problem to add to their list was reported by 6 participants, with one participant describing it as, "It was the cherry on the sundae," and another saying, "You think, crumbs, what next?" 3 studies then described the VT event as being a setback in daily life, with feelings of anguish and frustration described, due to the VT symptoms and the cancer treatment being affected. The setback was reported by 10 participants and described as, "Well, I'm going to overcome cancer, but no, then I started to go down again." Another stated, "Frustration of not being able to be where they should be." And another saying, "I couldn't do anything, it was that bad." Participants wanting normality was expressed by 3 participants, with one stating, "You want to try and recover and get back to some sort of, normality." Lastly, treatment for VT came with its inconveniences, but was well accepted amongst those with a CAT. Treatment accepted was mentioned in 4 studies. It did, however, come with negative experiences in 3 studies, with 6 participants describing the heparin as being painful, and 11 individuals stated that bruising occurred. The inconveniences and restrictions when treated with warfarin was also expressed by 9 participants due to the hospital appointments, the blood monitoring, and the dietary requirements. Although negative experiences occurred, treatment was accepted and viewed as necessary to prevent another VT event by 24 participants. One participant stated, "I really don't like pricking myself, but if that's that or dying, well, I'd rather prick myself." The treatment was seen to be included in their daily part of life and a routine, which was voiced by 9 participants, with one saying, "Because I do it as soon as I get up, and then if I have to go anywhere, it's all done and dusted." Therefore, 4 important themes have been discovered in order to answer the research question. Patients with a CAT have been heard within these findings discovered, which would not have happened or been uncovered if this work wasn't undertaken. So to conclude, this piece of work aims to generate new knowledge for both healthcare professionals and those affected by the condition, to be aware of the emotions experienced by those with a CAT and how best to support them. The need for further research on the emotions experienced by cancer patients in specific areas of the cancer journey and the best way to support patients with the CAT has also been identified. Recommendations from this work highlighted that education is essential for both healthcare professionals and cancer patients to be aware of the increased risk of CAT and the symptoms, which can be both physical and psychological. For a CAT information leaflet to be provided to cancer patients, for a CAT pathway to be recognised and to manage CAT effectively, for further research on the emotions experienced by those with cancer and a VTE, especially focusing on specific cancer types and stages, setting timescales to help healthcare professionals to recognise how and when best to support individuals with a cat. So what next? I've shared this piece of work at a local level and now much wider through this Let's Talk conference, updated the VTE Prevention and Safe Anticoagulation online educational materials for healthcare professionals, included information about CAT and the signs and symptoms in both staff and patient newsletters, developed a specific hospital CAT leaflet for patients, currently putting a business case together for a CAT clinic, which would incorporate both prevention and treatment as well as psychological support. And alongside this business case, I am collating local data on patient awareness of CAT, healthcare professional awareness, and their confidence in how to manage CAT in order to help build the business case further. And lastly, I'm currently working with Thrombosis UK, designing a national VTE app all about blood clots, which will include information specifically about CAT. Thank you so much for your time, and I hope you've learned something from my presentation. Any questions?
Yes, we have some questions. I've just been told to unmute, sorry. Fascinating stuff, Sarah. Thank you very much. And obviously, as a psychologist, close to my heart. Got two questions for you.
Yeah.
The first is, I suppose, how much did those findings resonate with your own experience? Because you've obviously, been working with people with these problems. And how good are we at spotting the psychological problems that people may be experiencing?
So during usual day-to-day work, they weren't groundbreaking results I saw this day to day. So it was really nice to actually have time to see, is this just where we are locally, what we see, or is this what's seen elsewhere? So actually diving into research that's already been done and seeing what I see also was good to see, to know it's not just our area, it's across the board. And I just found it really fascinating that other things was also uncovered throughout me looking into the themes. For example, the setback, I didn't really acknowledge that at first. I did about the treatment and the shock, because to me they were quite obvious things, but the setback was something that I wasn't quite aware of, and it was really interesting to see quotes from patients and what they said.
That was, I mean, it's an accumulation of problems, isn't it, for these poor people that are having them. Time's a bit limited, but the next obvious question is, could you expand a little bit on what support you think these people may need, and who can provide that sort of support?
So obviously quick fixes are like leaflets, but obviously we're reliant on staff giving out them leaflets, adding the information to resources we have available, like we're going to add this information to an app that will be available to all to use. But the support, it's really then signposting them to what's available. So there's a lot of information on the Thrombosis UK website about support. But locally, in like a service, it'd be really good to have our own psychologist where we could work together and refer patients to see them, because this work's just highlighted that that's really needed and that's what their need.
Well, I guess also at the front line, if you in your day-to-day interactions with these people, you can provide some support. So it's, much as I'd like you to see a employer psychologist, I think there's I think you guys at the front line are also absolutely critical in sort of helping these people sort of manage it. So yeah.
So if we can pinpoint them to this leaflet's available, this app resource is available, because we are very aware time is a restraint for us all, and we're seeing more and more patients, and time is limited, but if we have these resources that we can use and pinpoint them to, I think that's the best we can do at the moment.
Absolutely. And indeed, time is limited, so I'm going to have to stop the questions now. So thank you very much, Sarah. That was a really interesting talk and a good start to the session. So,
Thank you.
Thank you. Okay, thank you. For those of you that have just joined, you may be unaware that Sarah was actually pre-recorded. So there's a couple of questions come through that we can relay to her. But for the future talks in this session, the aim is to do them live, thank goodness, and to have roughly 15 minutes worth of talk and then 5 minutes worth of questions. So if people do have questions, can you either put them through the Q&A or the chat processes within Zoom, and I can do my best to relay those to the speakers. It's rather better that than everybody sort of shouting or trying to talk. So, so thank you very much, Sarah, even though you're not there and it was recorded, and we'll pass on to the next person who's also from Oxford. And I'd like to welcome Victoria McDonell. Victoria, it says Vicky, so I'm getting very informal now. She's the lead anticoagulation and thrombosis pharmacist at Oxford hospitals, and obviously is involved in anticoagulation management, patient safety, training and education. And the title of her talk is Pharmacist-led Warfarin Review Clinic. So over to you, Victoria, or Vicky, if I may.
Thank you, Paul. Just check you can see my slides there.
All good.
Thank you. So thank you, Paul, and thank you to Thrombosis UK for inviting me to present and share my work today. So I'm going to start with some background to help understand our local services in Oxfordshire. Since 2016, there has been a pharmacist-led anticoagulation service to support primary care. This started as an expansion of the secondary care role and is supported by one of our haematology consultants. We also work closely alongside specialist thrombosis nurses within the team. The service that has been provided has evolved over time to meet the changing needs within primary care. So the Oxfordshire Anticoagulation Service is a dose and post warfarin service, with GPs being responsible for prescribing warfarin and undertaking annual anticoagulation review. During 2021, it came to light that there was possibly a gap in the care for patients who were not getting their annual anticoagulation review, possibly due to the pressures on primary care over the last few years. So our aim was to address this by offering telephone consultations to those patients on warfarin with a low time in therapeutic range, or TTR. We wanted to explore the reasons for poor control on warfarin and to address any modifiable factors for improvement. We wanted to investigate if they were clinically appropriate to switch to a DOAC and therefore provide a recommendation to the GP. Ultimately, we wanted to optimize anticoagulation, reduce the potential for bleeding and/or clots, and improve patients' knowledge and understanding. It took some time to develop SOPs and letter templates before carrying out a mini pilot to test our processes. NICE AF guidelines recommend that patients on warfarin with a TTR less than 65% should be reviewed. We started with a 40% limit to create a more manageable list. As this list is also static at the point of download, it was preferable to keep this up to date by doing repeated lists. Of note, we included all patients on warfarin, not just those with a diagnosis of AF. Patients were excluded if they were no longer on warfarin, For example, it had been recently stopped or they had recently passed away. Those patients whose TTR had improved and other alternatives were not suitable, such as self-testing or movement to a DOAC. And those patients who were due or who had recently been seen by hematology or cardiology were also excluded. Having identified the patients, they were then triaged to get a better understanding about them. The GPs were contacted to inform them of the planned review. This was also an opportunity to gather information. A letter was sent to the patient to inform them of the appointment, and we also included in that a number of basic questions to help them consider in advance of the appointment, such as why do you take warfarin? Why might your control be poor? And also to ask about their current medication, including non-prescribed medicines. Throughout the process, we gathered information such as past medical history, current medicines, bloods, weight, INR testing, etc., which we built on in the actual consultation. Gathering this information in advance of speaking to the patient also allowed us to gauge what direction the discussion might go. So, for example, were they suitable to be considered for a switch to a DOAC, or did they need to remain on warfarin? In the case of making a switch, we actually advised GPs rather than initiating that, partly due to the logistics of undertaking a telephone appointment rather than having them face-to-face in clinic. Once we had spoken to the patient in clinic, an outcome letter was sent to both the patient and the GP. If the patient remained on warfarin, then we rechecked their TTR after 3 months. If they were going to be switched to a DOAC, we also followed that up to track that that had been actioned in primary care. A number of surveys were sent to patients to gather information about their views on the new service. So of the 150 patients identified, 44 were excluded and 106 were booked for clinic. 81 patients remained on warfarin. 38 had a mechanical heart valve. 30 had a contraindication to a DOAC, and 13 declined a change to their medicine. For 10 patients, we recommended a switch to a DOAC, which was actioned in all cases by primary care. Unfortunately, 9 patients did not answer the telephone despite repeated attempts, and a further 4 declined in advance of their booked appointment. For 2 patients, the date of their appointment coincided with a period in hospital. So for both of these patients, we contacted the medical teams and discussed their cases, and in doing so, switched them both to DOACs. For one patient, we subsequently followed up with a telephone call to them once they were discharged to help with reinforcing some counselling. For 13 patients, specialist advice from either haematology, cardiology, or vascular was sought. And in the case of 5 patients, the INR range was actually changed. Figure 2 shows the mean TTR before and after the clinic. This increased from 44 to 53%, which was deemed to be statistically significant. For patient feedback, of the 37 surveys sent out, 8 were returned. All patients rated the level of information provided as very good or good. 100% of patients felt better informed about their medication. that the pharmacist had spent enough time with them, that a telephone consultation was suitable, and that they were satisfied with the outcome. We also had a number of other positive comments, which was great feedback to hear, particularly with a new service. So in conclusion, for most patients identified for review, telephone consultation was successful. Only a small selection of patients were eligible for a DOAC. And therefore, in the main, warfarin continued to be used in many patients. The reasons for continuing warfarin included mechanical heart valve, an INR range other than 2 to 3, severe renal impairment, high body weight, and medication interactions. For those patients that remained on warfarin, we saw significant improvement in their TTR. Access to specialists in secondary care provided valuable clinical support, which perhaps would have been more difficult to have obtained in primary care. We've continued to build on this work, making the clinic part of our regular work. This has allowed us to review many more patients and therefore provide valuable interventions into their care. We hope that in time we can reach out to all patients and even possibly consider those well-controlled patients who might benefit from a review in other ways. Thank you for your time, and I'd be welcome of any questions.
Excellent. Thank you, Victoria. That's excellent and very interesting talk. Do you want to click off the video so we can see you a little bit bigger, if that's possible? Excellent. Marvelous. So I've got a question. We have a question from Katie Jenkins. It's a very specific one. What was the body weight cutoff for switching from warfarin to a DOAC?
Okay, so locally, we have some guidelines whereby we generally say that if patients are over 120 kilograms, we would be cautious about using a DOAC. But between 121 and 150, a DOAC can be considered for both AF and VTE, depending on the individual patient themselves. But we generally don't tend to use DOACs over the 150 kilograms.
Completely over my head, but I'm sure that was very useful for people to know about these things. I have a question, which is, what do you think was why did people change? What happened in that consultation? I know you haven't got the evidence, but from your own sort of understanding of what was happening, and why did people improve their adherence to warfarin at that point?
So I think for some patients, it had been quite a long time that they'd been on warfarin, it was perhaps reinforcing some of the basics of what they needed to do. So we talked, for example, about diet and were they having a regular eating pattern, what they were eating, including alcohol intake. So for a few patients, that was something that came to light. For others, it was around their medication. So for some patients, we did flag up that perhaps there'd been a period of time when they'd had some medication changes which had settled down. So perhaps less of our involvement, but for them to at least understand that that might have impacted on their INR at that particular period in the past, which had led to their poor TTR.
So in a way, it was that provision of relevant information that was the critical thing. Yeah.
Yes, I think so. And for a few patients as well, just a little bit of a reminder about INR testing and going on time. So that helped perhaps nudge a few people to become more regular with that. And so we had therefore shorter periods when perhaps they were out of range and they were being more compliant with that.
Does that have presumably these people were coming in for regular INR monitoring. So does that suggest some issues that maybe could be looked at within that sort of monitoring process?
So for most of our patients, they go to their GP surgery for their blood tests. And then they are dosed remotely from the hospital. So we did ask questions around how they felt that testing was, and there were just a few patients who did flag up that it was quite difficult to get appointments. So we did pop that in the letter to the GP, just to make that perhaps something to discuss further with their colleagues.
It's interesting because I'm a psychologist, obviously, I've already said that, but I actually, I have sat in a couple of INR clinics over the years, the warfarin clinics, and I've heard pharmacists discussing the secondary versus primary care issue with some interesting views. So I'm wondering what your view is on that, based on what you found in this particular study.
In terms of where they get testing,
yeah, where best that care should be provided.
Yeah, I mean, I think having easy access to the GP practice, being close to home, probably seems to work quite well. We certainly couldn't be having all those patients come to the hospital. We have around 2,000 to 2,500 patients who we manage, who the anticoagulation service manage on warfarin, and that just would not be practical. And also for a lot of patients, the mobility or perhaps even just transport into Oxford from their home would be a difficulty. So I do think it works quite well for patients to have those blood tests in primary care. That said, we do have a small number of patients who are on home visits because they're housebound, or perhaps if they're very difficult to bleed, they do come to a finger prick clinic that we do operate from the hospital for those selected patients.
Thank you.
So I think perhaps one thing doesn't always fit everybody.
Sure, absolutely. Yeah. That makes a great deal of sense. Did you encourage self-testing at all? Was that something you did?
Yes, we did. We because of the discussions around testing, it also gave us that opportunity to highlight self-testing. Unfortunately, because of the cost of the machines, that became something which seemed to be quite a barrier for a number of patients. I think particularly in the economic climate of the current situation, that meant that for many patients that just was not proceedable. But at least for those patients who felt satisfied with their current testing, it was just an opportunity to raise it for perhaps even the future if their mobility did decline, or that was more difficult, with some patients relying on perhaps friends or family members getting them to the surgery, and that left something for people to think about, certainly if their situation changed, that they might consider.
Excellent. Okay. Well, I think we've addressed all the questions, so I think it's time to say thank you very much, Victoria, for an excellent and very interesting intervention, and we'll pass on to the next talk. So thank you very much. And I think Sharan has just appeared. So the next talk is by Sharan Reghunathan, and an incredibly long title, which I will sort of summarize. It's looking at the prevalence of genetic loci associated with VTE based on large-scale whole genome sequencing database of 3 Asian populations. So we're moving from the provision of service to a much more technical talk here, which I'm really looking forward to. So Sharan is a 5th-year medical student at Manchester, already done a degree in medical genetics, and I've never heard of it, but I'm assuming this is wonderful. He's won the Bobrow Prize in medical genetics, so clearly a rising star. And we're really looking forward to your talk, Sharan. So off you go. Are we dealing with the technical things here?
Are you okay to share?
Yeah, we're getting there. Excellent.
Is it clear now? Can you hear me clearly?
Yeah, it's clear and we can hear you.
So thank you so much.
Sorry, I know I should have mentioned, I do beg your pardon. With Sharan is Dr. Eugene Fan. So it's a double presentation here, who's a consultant hematologist in Tan Tock Seng Hospital in Singapore. So over to you guys. No more interruptions, I promise.
Thanks, Paul, for the very kind introduction. Good morning to all in UK, and warm greetings from Singapore this afternoon here. Sharan and I would like to thank Thrombosis UK for the very kind opportunity to present our findings. And we're very pleased to be here this morning and this afternoon. Next, please. And these are our disclosures. And I'll be touching on the background, aims, methods of our study, and part of the results inclusive of population demographics. Sharan will be doing the honors and sharing the genetic variants associated with VTE, our main results, and as well as the discussion. So the question really is, does the incidence of VTE vary across different populations globally? And you can see here in the box on the left, that Western countries do have a higher prevalence of VTE, so approximately 100 cases per 100,000 patient years. In the UK, it is averagely about 75 cases per 100,000 years. Now, comparing this with Asian countries, East Asian countries and Singapore, this is by far much lower. Next, please. And if we look at the Asian population studies, you can see here, this is mainly from East Asia, Japan, Korea, Taiwan, Hong Kong. The VTE rates are lower, ranging from 8.8 to 19.9. And if you average that out, that's around 15 cases per 100,000 patient years. So we really know that, the evidence indicates that VTE is a multifactorial disorder, and it involves both genetic as well as acquired risk factors. Now, the box on the left, the blue box shows the genetic risk factors that we know, and there are acquired risk factors in the purple box. And so this culminates in a phenotypic expression of thrombosis. One may ask, if you remove the environment from the equation, what does that leave us? So next slide. So we have an interesting study out of New Zealand, where they looked at the incidence of VTE in different ethnic groups. You can see here in New Zealand, the Europeans and the Africans had the highest rates of VTE, followed by the Maori and the Pacific Islanders. And right at the bottom are the Chinese and Indian ethnicities. And many of us know that there are genetics associated with VTE. Many of the early discoveries were in the 1960s, where we found genes that implicated coding for protein components of the classic coagulation cascade. So if you look at the box, you can see protein S, protein C, antithrombin, and activated protein C there. But since then, our understanding of genetic influence on VTE has expanded. And we now know that there are other genes that have a functional role out of the classical coagulation cascade. And this implicates other kinds of cells and pathways, including that of hematopoietic cells, namely immune cells, red cells, and even platelets. So what about thrombophilia in the Asian context? This is a recent study coming out of East Asia, done about 2 months ago. And you can see very nicely that the East Asians have a high prevalence of protein C, protein S, and antithrombin on the table on the left, with very low factor V Leiden and a prothrombin gene mutation. And the graph on the right clearly shows that the phenotypic expression is different across the Western part of the world and in East Asia, where in the West, the blue lines show that there's increased prevalence of factor V Leiden as well as prothrombin gene. And this is converse in the Asian population. So what I've explained is that in summary, the VTE appears to be more common in European populations, whereas in Asian populations, this is lower. We know that genetic variants link susceptibility of individuals to VTE. However, there's a paucity of studies explaining the ethnic differences in susceptibility to VTE. So Singapore is well poised, given our unique history of immigration. And we have a whole genome sequence analysis of close to 10,000 Singaporeans, which can provide a good snapshot of the genetic variation of the VTE genes of interest in Asia. So our study aimed to compare the prevalence of established as well as novel genetic loci associated with VTE from a whole large genome sequencing database. It's called the SG10K database and is supported by Precision Health Research Singapore. And essentially, the SG10K database sequenced over 10,000 whole genomes and got roughly around 2 petabytes of data, which is equivalent to almost 7 million TikTok videos. And the data spanned across phenotypic as well as genomic data. We were interested in the genomic data. Next, please. And here are some of the demographics. We had 6 research cohorts, predominantly female, healthy volunteers. We had a span of volunteers from newborns all the way to adults from 18 to 84 years. The predominant ethnicity group was Chinese, followed by Indians and then Malays. This is my last slide. I'm going to share our methods. We did a literature review and curated the genetic variants linked to VTE. We looked at the NOMAD as well as our own database of SG10K Health. And this was through the Common Variant browser. And now I shall hand the time over to Sharan, who will share with us the results. Sharan, please.
Sorry. So hi, everyone. My name is Sharan. So thank you, firstly, for the chance to present, as well as this opportunity and for the kind introduction, Paul. So what I'd like to spend some time now doing is to talk about our results. So in this table here, we've highlighted the results that we obtained when looking at the factor V Leiden variant and the prothrombin G20210A variant. It's interesting to note that the two variants that are commonly tested as part of thrombophilia screening are more common in European populations compared to the Asian populations. The prothrombin variant is even absent within the Singapore Malay population. Our research also highlighted that variants in protein C were more prevalent in Asian populations. But when looking closer at the data, protein C and protein C receptor variants have the highest prevalence rates in the Indian population. We also analyzed 3 protein S variants, 2 of which were reported to be missense, and we finally looked into the antithrombin variant. This variant was absent in both Chinese and Malays and had a minimal allelic frequency of approximately 0.12% in Indians. So for the next part, I'd like to spend some time talking about the implications of our results. So firstly, the factor V Leiden variant. So arising from a single point variant, the factor V Leiden variant is a well-known single nucleotide polymorphism that is associated with VTE in European populations. This variant results in protein C being unable to bind onto factor V, leading on to an increased risk of thrombosis. Our study shows that this variant appears to be more common in European populations, but has low prevalence rates in Asian populations. It had a low overall allelic frequency of approximately 0.33%, with the lowest allelic frequencies observed in Chinese and the Malay populations. This aligns with prior research indicating a low occurrence of this variant in other Asian populations. Hence, we suggest that this variant may not contribute as significantly to the development of thromboembolic disease in Asian populations. Hence, the utility of screening for this variant in Asian populations may not be so cost-effective. We also spent some time looking at the importance of factor II. Factor II is vital in the coagulation cascade, playing a role in thrombin generation. Thrombin's roles include converting fibrinogen into fibrin, activating factor 13, and amplifying the coagulation cascade. It has been reported that this variant can increase clotting risk by increasing the production of prothrombin. Indeed, the relative VTE risk for this variant is 1.7. Literature searches reveal that this variant is rare within Asian populations, and our findings are in keeping with this. Our study supports this as we noticed that there was an almost twofold lower overall prevalence rate of approximately 0.068% in the European population and was even absent within the Malay population. Further, a GWAS study showed that this variant was not associated with VT susceptibility in East Asians. We then looked into the role of protein C, which plays a role in preventing excessive blood clotting by inhibiting factors 5A and factors 8A, and indirectly regulating thrombin. So genetic variants affecting protein C activity can increase VT susceptibility. This study found that protein C and protein C receptor variants are common in both Asian and European populations. Notably, Asians, especially the Indian population, have a high prevalence rate of this variant. This suggests the importance of emphasizing protein C testing for VTE diagnosis in Singapore, especially those of Indian descent. Additionally, this study underscores the need for further research to understand the downstream implications of this variance, many of which were found in non-coding regions. We then looked into protein S, which again is an anticoagulant, which serves to assist protein C. It prevents excessive clotting and maintains vascular health. So protein S deficiency is a rare disorder that leads to an increased risk of thrombosis. And our study supports this as 2 of the 3 VT-associated protein S variants are rare within the European and Asian populations. These variants are even absent within the Indian and Malay populations. This finding suggests that a greater focus on protein S testing should therefore be placed on individuals of Chinese ethnicity. Finally, we looked into the role of antithrombin, which serves as an anticoagulant. Antithrombin not only inhibits thrombin formation, but also factor 9A and factor 10A. Deficiency in antithrombin is linked with thrombosis and thromboembolism, and our study looked into the prevalence rate of a VT-associated antithrombin variant. Known as the antithrombin Dublin variant, this missense variant is associated with a twofold increase in VT risk in European populations. Our study showed that this variant was absent in the Chinese and Malay populations, but was only present in the Indian population. So we suggest that a greater focus on antithrombin testing should therefore be placed on individuals of Indian ethnicity. So just to summarize what I've spoken about so far, this is a heat map, and the bird's eye view shows different prevalence rates of different VT-associated loci. So red indicates high prevalence rates, while green indicates low or no prevalence. So we can see that that the factor 5 variant and the factor 2 variant has the highest prevalence rates in the Middle Eastern populations, followed by the Europeans. In our cohort, it is high in the Indian population, but markedly low in the Chinese and Malay populations. When looking at the protein C variants, we can see that the Chinese population has the highest prevalence rates. Likewise, the antithrombin is absent in Chinese and Malays and has a low overall allelic frequency of approximately 0.12% in Indians. So this is a table just to summarize how our findings is in keeping with other findings that we have observed in Singapore. So the table on the left shows the inpatient admissions of VTE in Singapore. The incidence is highest in Caucasians and Eurasians, followed by Chinese and Indians. So these inpatient findings correlate with our population studies that Dr. Eugene shared about earlier. The table on the right shows the data that we obtained from 384 patients with VTE in Singapore. This correlates with our findings, and protein C, protein S, and antithrombin have the highest rates. Protein S has high prevalence rates in Singapore, possibly due to the large percentage of Chinese population within the country. There's only one case of factor 5 laden variant, and the prothrombin gene variant was absent. And this is once again in keeping with our findings. So what does this all mean? VT is a complex disease with known genetic factors in European populations, but its genetic basis in Asian populations still remains largely unexplained. This study found significant overlap in VTE genetics between Asian and European populations, but also identified unique differences amongst the Asian groups. Generalizing European genetic findings to Asians is therefore unreliable, and this research highlights the need for further tailored VTE screening programs for individuals of Asian heritage. By stratifying VTE screening based on ethnicity, it may be possible to detect VTE or its precursors early, thereby delivering patient-centered care. But it's important to recognize that VTE is a multifactorial disease, influenced by both genetic and environmental factors. The study did not look into the role of environmental factors. We also highlight the need for further studies to look into the downstream implications of VTE-linked variants. This means if an individual has a VTE-associated variant, what are the chances of them developing VTE? Does the same gene variant or gene combination produce variable phenotypes in individuals? We weren't able to do this in this study as we only utilized healthy individuals, but the incorporation of such individuals could theoretically have given us a higher yield in the discovery of the genetic determinants of VTE. So just to wrap up what we've spoken about so far, this study used whole genome sequencing and the Course variant browser to analyze VTE-associated genetic variants in different Singaporean population groups. We have revealed the complexity of the genetic factors involved in VTE, including coagulation pathways. Notably, the study explored the genetic susceptibility of VTE in Malays, and a group of Austronesian people of around 400 million people, of whom VTE has not been examined so far. While some genetic factors overlapped between the different populations, we have highlighted the need for customized screening for VTE in individuals of Asian descent. Cost-effective screening strategies were recommended, such as focusing on protein S variants in Chinese individuals and antithrombin and protein C variants in those of Indian ancestry. However, further functional analyses are still needed to investigate these associations further. So with that, I'd like to thank you for listening and hope to answer any questions you may have.
Wow. Thank you both. I was dreading that talk, I have to say, because I know nothing about physiology and I know nothing about genes, but actually, I'd really like to thank you for making it so comprehensible, because I think I nearly understood it, which is absolutely amazing, to be absolutely honest. I've got a question which is really, my questions are going to be very naive, so bear with me and feel free to tell me I'm talking Tommy Rot here. But I suppose the first question I've got is how much of the variance in presentation of VTE or development of VTE is attributable to genetic factors? You know, you talked about environmental and all these other factors. So, you know, in the flow of sort of medical care for patients, how important is that genetic process in risk identification and treatment?
Is it fine for me to answer that question, Dr. Eugene?
Right.
Yeah.
Thanks for the question. Good question. I would say having thrombophilus genes predisposes one to have higher thrombotic risk. And if there is an incident event, say like surgery, that tips the patient over the thrombotic threshold, leading to thrombosis. So obviously different genes have different risks. And we know that the antithrombin gene has the highest risk compared to protein C and protein S, whereas factor V Leiden, which is quite common in the Europeans and discovered in the Netherlands, is on the lower end of the risk spectrum. So when you have like an antithrombin gene, this really puts you at high risk. And if there are other factors such as COVID or immobility in hospital, any part of the workout triad, it might tip you over into getting a thrombosis. So having that assessment in special populations is key. We shouldn't indiscriminately test patients for all these genes. But I think increasingly we are seeing a shift in paradigm where previously we used to clinically classify VTE as as provoked or unprovoked. But really this is more like a continuum now that these genetic factors are coming into play and are also diverse in quite a different spectrum across different ethnic groups. I hope that answered the question.
No, it's fascinating. I mean, at the moment, I know in general medicine, they're talking about, sort of doing, genetic sequencing, identifying individual genes, so you can then tailor the intervention to the sort of individual biology, biochemistry, or whatever. Is that something that this could lead to in VTE treatment?
Yeah, I think so. I think we are moving down the road of personalized medicine. So we don't know much. I think unfortunately, I think Sharan and I have just scratched the surface of genetics in VTE. There were many other genetic loci that we actually pulled out, but it was beyond the scope of this presentation to discuss. And honestly, we were not familiar with them. We discussed the ones that we were more familiar with. And I think there's a lot of work to be done, beyond just all these genes. Even the literature on genetic predisposition or predictors for recurrence of VTE is not well studied. And there is a lot of work to be looked at in this aspect. Sharan, you want to add on? Any thoughts?
Yeah, I think it's just in sort of keeping with Dr. Eugene's thoughts. We are moving towards an era where genetics is going to play a key role in how we tailor treatments. And at present, we've kind of just looked into the role of exon variants. So these are protein coding regions, but as mentioned earlier, there are a lot of variants that are in non-coding regions as well. And so I suppose the next step is also to identify what are the implications of these variants, and also how the phenotypes can vary depending on the combinations that may be present. But I think that's an exciting time, and it's something that's for the future.
So talking of the future, do you have, what plans, if any, do you have for further developments along these research lines?
I guess I can answer that.
Yeah, you're the boss, so you should answer that one.
No, credit goes to Sharan for driving the project. So I think we need to work across our silos, and actually, honestly, very pleased to be here, invited by Thrombosis UK to discuss. And this is all part of the World Thrombosis Day celebrations. We've had a sort of talk at Singapore General Hospital just last week. And I think you're leading up to your celebrations on the 13th of October in the UK. The research needs to be, across boundaries and transnational, rather than just siloed within Asia or, in Europe. So we do have a long way to go, but really pleased that we have several platforms of collaboration.
Excellent. Right, on that positive note, I think we're going to have to move on, but thank you very much. And we have an international audience, so maybe we have international research, international audience. It's all looking good. So, but no, thank you for your time. What time is it in Singapore at the moment? Is it some horrendous time that you're?
Now it's just after work, 5:20. So it's a good time.
No problem. Okay, thank you very much, Eugene and Sharan. That was excellent and very interesting talk. And there we go. So we'll now move on to what I hope will be, I'm sure will be another interesting talk by Inaul Hussain, coming back to the UK now. And this is going back more to the service provision end of things. He's going to talk about an audit to assess the appropriateness of VTE prophylaxis at his local hospital. And Inaul is the lead pharmacist for anticoagulation in a long one, Barking, Havering and Redbridge University Hospitals NHS Trust. Just about got that out. But you're a rare thing, you're an independent prescriber and sort of leading developments. And so I'm really looking forward to hearing what you have to say, So over to you.
Thank you, Professor Paul Bennett. I'm just going to share my screen now. Okay,
Perfect.
thank you, everyone. Okay, so thank you very much. Good morning, everyone. And thank you to Thrombosis UK for the lovely invite and opportunity to present and share the work. So today I'm going to go through my audit, which is on the appropriateness of VTE prophylaxis at our trust. And the overview, we'll go through the introductions, aim, objectives and standards. We'll look at the methodology. We'll look at the results, analysis. We'll touch on our strategies and interventions and key actions and recommendations. We'll go through how patients and the NHS benefit from this service and going forward, what we plan to do and acknowledgements as well. Okay, so venous thromboembolism, VTE, commonly known as blood clots, is a significant international patient safety issue. The first step in preventing death and disability from VTE is to identify those at risk so that preventative treatments can be given. A VTE that occurs within 90 days of hospital admission is known as hospital-acquired thrombosis. And according to Thrombosis UK, 55 to 60% of VTE cases occur during or following hospitalization. A VTE is a common and potentially preventable problem, and it's the primary cause of preventable deaths in hospital. 1 in 4 people die from causes related to blood clots. How will you know if you have a DVT or PE? So just briefly, the symptoms of DVT in the leg include swelling, pain, warm skin, tenderness, redness, particularly at the back of your leg below the knee. And DVT usually, although not always, affects one leg. In some cases, there may be signs or symptoms of DVT at all in the leg. The symptoms of PE include shortness of breath, pain in your chest, that's worse when you breathe in, and in severe cases may collapse. Both DVT and PE are serious conditions that require urgent investigation and treatment. DVT is a common medical condition, which I've mentioned, but it forms in the vein, usually in the leg or the pelvis. It can block off or reduce the flow of blood in the vein. DVT in the leg or pelvis can cause pain and swelling in the leg and may result in lifelong disability with painful swelling, varicose veins, and leg ulcers. The pathophysiology of PE, sometimes in the DVT, blood clot in the leg breaks off and travels to the arteries of the lung, where it will cause a pulmonary embolism. PE may cause breathing difficulties and chest pain and may be fatal. So both DVT and PE collectively are known under the collective term of venous thromboembolism. Now, just to explain why the need, NICE in 2018 recommends the assessment of all medical, surgical, and trauma patients to identify the risk of VTE and bleeding as soon as possible after admission to hospital or by the time of the first consultant review using an appropriate risk assessment tool from the Department of Health VTE risk assessment tool, which is commonly used. Now, VTE prophylaxis is an issue across all NHS trusts, and it's a national problem, including hospital-acquired thrombosis. NHS England and NHS Improvement VTE risk assessment data collection from October to December 2019, Q3 reveals that 95% of inpatients aged 16 and over at the time of admission to NHS-funded care received a VTE risk assessment. Despite the above cited national findings, the Trust was recently issued a Regulation 28 report to prevent future death by the coroner following a case of hospital-acquired VTE. In response to this, together with incidences of hospital-acquired thrombosis, and in line with the Trust learning from incidents and culture of continuous improvement, a preliminary audit on 5 medical wards at the Trust was conducted 18 months ago, where compliance with risk assessments at 24, 72-hour, and changing clinical conditions showed very poor figures at 1%. Following this, I was appointed Pharmacy VTE lead, and together with Mr. Ressa Reddy, medical VTE lead, Rianne Green, the VTE lead nurse, and Deborah Wickens, lead nurse for Humphrey Care, we formed the VTE team at VHRUT. So the objectives of this audit include to determine if all patients have a VTE assessment carried out on admission, a 24-hour reassessment, a 72-hour reassessment, and to determine if all patients have a change in clinical condition reassessment as well, and also to determine if all prescriptions reviewed have appropriate thromboprophylaxis prescribed. And these were our standards. 100% of VTE risk assessments are carried out on admission, 100% at 24 hours, 72 hours, and if there's a change in clinical condition. And also regarding the thromboprophylaxis prescription, 100% of prescriptions have appropriate prophylactic dose prescribed for renal function, and also appropriate dose prescribed for patient weight. Now, the low molecular weight heparin heparin that we use in our trust is clexane, also known as enoxaparin. This figure 1 shows the current VTE risk assessment and thromboprophylaxis treatment section of the paper prescription chart. Okay, so what did we do? As part of this QI project presenting today, I initiated the first trust-wide audit in November 2022 on 39 wards across both sites, and again 6 months later in May 2023, in order to assess the adherence to the clinical guidelines recommended by NICE and the VTE policy to improve practice by identifying deviations from the policy, establish clear recommendations, and also to enhance patient care and address the concerns of the coroner and reinforce learning within the organization to prevent future incidences. The exclusion criteria mentioned there, so any patients under 16 years of age, pediatric and neonatal, women and children, and ED on both sites. Also, the audit was carried out on the first 10 patients per ward. Data collection was conducted electronically on MS forms by pharmacists and technicians. Results. So overall, there has been a significant improvement within a 6-month period. However, there is scope to bridge the gaps. But we can see that trust-wide VTE risk assessment compliance has improved from 35% to 53%. In addition, compliance with thromboprophylaxis prescriptions has also increased from 92% to 95% from November to May. And these are the results according to our standards. So regarding VTE assessments on admission, excellent, 99%. Significant jump from 24 to 40% at 24 hours, for 72 hours, again, from 9.5% to 33%, and also a big jump for changing clinical condition reassessments, 5% to 39%. Thromboprophylaxis prescribing for renal function, steady at 98, 97, and for patient weight, slight improvement as well from 85 to 93%. And this is the graph representing our care groups. Or clinical divisions or directors, whatever you are familiar with. So specialist medicine, surgical critical care and anesthetics, cancer and clinical support, and emergency department and acute services. And further breakdown by the standards. So as we can see, huge progress from January, the initial preliminary audit, then in November, and now in May. So I've just gone through the key successes and just to elaborate. So substantial improvement in prescriptions with appropriate prophylactic dose prescribed for patient weight, and also key concerns, like, as we've seen, significant shortfalls continually in 2472 and changing clinical condition, despite the improvements. 33 doses, 18 doses, including patients refusing, of clexane in the total across the trust were omitted. Reasons for dose omissions varied from unable to confirm, no documentation, not signed for, but that will be audited separately in a delayed and omitted doses audit. Pharmacist interventions required for appropriate VTE prescription. So 18% of all prescriptions audited across the trust required pharmacist intervention. So practically 1 in 5 prescriptions required a pharmacist to intervene. Next. So how did we manage to roll out and get people on board? So looking at our strategy, so I'll be focusing on that, and how did we achieve our success? So VTE team are doing a lot of groundwork. So I have to say credit to all the consultants, nurses in charge, matrons, ward clerks, pushing the drive. We have seen big strides in the care groups, especially medical and acute admissions, with significant and consistent improvement. And I have to say, our champions, our nurses and ward clerks, really driving the initiatives. Several initiatives we have taken place between the audits. So we have designed a logo for VTE to raise awareness. With the help of IT, we created screensaver messages on all trust PCs and at both sites. As part of World Thrombosis Day on 13th of October, and this week, we're conducting lunchtime lectures throughout the day. And for high-profile guest speakers come to our hospital and speak on VTE. We've created a folder on Workspace, VTE folder, for everyone to access and read or refer to the news. other initiatives, so VTE policy and the Trust low molecular heparin prescribing guideline have been revised and up to date. I also created a new flex and shared care guideline for use between North East London and our BHIUT Trust. We introduced a VTE assessment column on the ward flow board to help verify assessments during board rounds, and we set regular reminders where possible. We created a VTE prevention learning tool, which has been introduced in Trust training source best, and that's now mandatory. We in VTE team regularly go through IR1s and RCAs and hold meetings to sign them off or call for roundtable meetings. And we conduct or attend other meetings arranged by QNS to learn more. We've also received educational cards and leaflets from Thrombosis UK to be distributed to patients. Our sister Reghunathan, lead nurse, visits ward regularly at both sites and reminds the nursing staff and juniors regarding assessments and clears any doubts raised. Matron Deborah Weekends has also managed well on leading and maintaining conversations with quality and safety and other care groups. So these were our key actions and recommendations. We've pretty much gone through them and actioned. It was very important that we ensured we raised an IR1 or incident report for all missed assessments and thromboprophylaxis. And that's the drive and challenge going forward as well to increase the reporting. Reasons for missed doses to be documented. And we're reporting all hospital-acquired thrombosis. Any late assessments need to be clearly documented with date and time. We're also giving the message to please ensure all patients have a wait documented for their current admission. And this is why we've seen an improvement in the figures. Yeah. And I've presented this report to our VTE group, grand round, divisional nurse meetings, medical meetings, safe medicines practice group, and trust, various trust QNS meetings as well. And now here at Thrombosis UK. Next audit is in January 2024. We'll be transitioning to an MDT audit instead of just pharmacy. So we will include doctors and nurses to increase greater awareness and reach out as well. So how do patients and NHS benefit from this innovation service or resource? Ultimately, a reduction in the incidences of hospital-acquired thrombosis by improved VTE risk assessments and appropriate thromboprophylaxis prescribing. Recent approval of an enoxaparin shared care guideline between BHIUT and Inaul means better continuity of care and potential reduction of missed doses through improved access in primary care. So this regular audit in place has improved vigilance across the trust and has improved education and training across the multidisciplinary teams. Patient safety has also improved as we now ensure we raise an incident for any missed anticoag doses, all missed assessments and thromboprophylaxis. We have observed improvements in the number of patients having weight documented, as I mentioned, which has resulted in accurate prescribing of Clexane according to weight and renal function. Okay, next. Going forward, so we will be transitioning to MDT audit. Digital services are forecasted, so EPMA and EPR forecasted for 2025, whereby risk assessments will be made mandatory on the electronic patient records. We now have a mandatory VTE learning module, audit of VQ, CTPA duplex scans, maybe going forward, mandatory monthly audits for wards via Safeguard, also looking at repeating the audit with ED, so devising a strategy for second assessment with long-stay patients. Okay, and I've mentioned the delayed and omitted doses are audited separately. Okay, acknowledgements. So I'd just like to thank everyone, the team members, Mr. Vesereddy, Rian, Deborah, and Dinesh for the lovely support. Everyone at BHIUT, so pharmacy, hematology, anticoag team, and harm-free care, really driving the initiative forward, and for the very hard work of the last year. And everyone at Thrombosis UK for giving us the opportunity to present and share our slides. And I'd like to thank Thrombosis UK and Lynn Brown for my warm invite to the House of Commons for VTE award ceremony, along with the team. And that concludes my presentation. So I'll now open up the floor to any questions. Thank you.
Thank you, Inaul, for some very important data and slightly worrying in a way. So do you want to cut your slide down so that we can actually see you as opposed to slides for the questions? Oh, I love these technical things. It's always a disaster, isn't it?
Very
Okay, well, we can see you. Don't worry. Yeah. Perfect. Well done. So I suppose you might not have the data for this, but subjectively, do you have any sort of ideas why you've got that improvement and what the barriers to further improvement may be? You know, I'm trying to drill down into, you know, is it that, you know, some teams are really good and some teams are really bad, or are all the teams pretty similar in its circumstances?
I think when we just, to start off with, the first preliminary audit, which was done on 5 wards across the trust, it showed the gaps in our risk assessments from prophylaxis prescribing. And when I did the first trust-wide audit in November, without any without any awareness in the trust, it was very similar across all the care groups in terms of our findings. And so what we did, I think the most important thing was raising awareness in the trust, what it is, the consequences of hospital-acquired thrombosis, with the significant comorbidities, can be fatal as well. So raising the awareness was one of our biggest challenges, and we've accomplished that in various ways, as I've mentioned, and explaining to everyone why we're doing an audit and getting people on board. That was the challenge, but it seemed to pay off because we've had a significant improvement over 6 months, and using various avenues and methods and strategies that really push the message across in the trust. So raising awareness was the biggest factor, and now going forward, the challenge will be maintaining this and also improving on our figures as well, especially in the absence of EPMA.
So if you have a thrombosis, a HAT, do you sort of go back and try and find out the causes and do that sort of root cause analysis and try and use that to encourage, shall we say?
Absolutely. So we have a designated VTE team. So all incidences are filtered through, and we investigate the IR1s within our team, roundtables, we do a root cause analysis, and then we take it from there. But obviously now with the introduction of PSERF, we'll have a different reporting system and learning as well. So that would be very exciting.
So you have to explain that to me because I don't know the acronym. So what does that involve?
So there will be new patient safety incident reporting framework across the NHS, and that will look at incidences in a different light. But ultimately, we will be looking at root cause analysis of our hospital-acquired thrombosis and taking it from there.
Okay, so I suppose going back, that initial data was during COVID, would that be right? So would that have been sort of almost lower than normal as a result of all the COVID sort of issues? I mean, is there maybe just be bouncing back to pre-rates or?
It may do. This is more of a prophylaxis. So we're looking at patients not for VTE treatment. We're looking at prophylaxis or preventing clots. So these are all patients that are coming to hospital requiring a risk assessment and requiring prescribing of a low molecular weight heparin to prevent clots from forming. So it's difficult to say whether it would have had an effect, but ultimately we looked at the prophylaxis data. Okay. But just to bear in mind, this is also a snapshot. So the first 10 patients on every ward. So the audit was designed in a way where it was feasible to complete across the trust. And it was, so that was not so difficult. First 10 patients on 39 wards across the trust. But I think going forward, we'll have a greater expansion of the team. So we'll have doctors and nurses on board for the data collection. So that should help disseminate information, findings, and then they can take away and disseminate education and training within their groups. So that would again raise greater awareness.
Absolutely. I mean, clearly something that needs to be repeated and kept going and feeding back and learning and developing. So it's good to hear you're actually doing it. So that's very encouraging. Okay, so we are coming towards the end of the session now. So thank you, Inaul, and thank you one and all for your various contributions. It's been a really fascinating and very interesting selection of talks. I've really enjoyed it. The only thing I can do is say thank you very much. Remind viewers that there are many more posters available on the internet through the Poster Hall, where you can read those. But seriously, thank you. I've understood almost every single talk, and I nearly understood the genetics, which I thought was a good victory. So thank you very much. And yeah, we'll draw the session to a close. But